Pam Matthews.
Thank you. Here we are. Okay. Couple of things before I get started. First of all, thank you so much for inviting HIMSS to be a sponsor of this event and for also inviting me to be on stage. Everyone knows, for those who know me, that's always a dangerous thought though, and I accept the challenge. With that, I also want to acknowledge something that is occurring within the state, which is next week, and you can get additional information over on our table. And for those in the HIMSS California chapters, please stand up. These will be your point people if you want additional information right over here. We are actually having California State HIT Day, and it's next Wednesday. The program's from 8 to 4:30. So see these two ladies if you would like to participate and if you have questions. Mr. Tom Keefe, who is over our state government affairs, will be attending, and I'm sure it will be a great event. We were laughing, saying too bad we both couldn't be here the same week so we could attend both of these sessions. The other thing, I want to have some acknowledgments. We did a double dog dare, and I've been spending the rest of the day convincing people I had nothing to do with this, Pam. For those who know me, they know that I do a lot with Border Collies, raising Border Collies and training them. And, you know, amazingly, some Border Collie pictures get in some of my presentations from time to time. So I've had the dickens, and I still think some do not believe I didn't have anything to do with this. But the double dog dare is, will you stand? If you have been and I just want to acknowledge so you can see the not only the participation at the state level, but also at the national level in terms of activity, not only within health information technology, but also health information exchange. We have a lot of activities, as everyone knows, at the national level, and we also value and utilize our volunteers. So if you've ever been a member of the HIE committee or you are currently a member of the HIMSS HIE committee, I dare you to stand. And I know there's a few others out there. Lyman, you're not standing. And then where is Aaron? Like I said, I'm daring people to stand. Is Aaron not with us yet? Also, those who've been a member of a task force or work group, if you dare to stand, we'd like to acknowledge you. Because I know Will Ross was here at one point. I don't know if he'll be standing. Very few times do I get to go to a state event, and I actually do that. So thank you for the indulgence, because technically or typically we don't have that many representatives at a national state event. And I was sitting up front looking at the room, and I'm going, Dave Minch was a charter member. We have Aaron, a current member. I could start naming off the folks who are in this crowd that have been participating at that national level. So some of you took the dare, others did not, so we'll pass on that. Now, to get started, I do know that I am in between you and the networking session, which is, I'm sure, going to have alcoholic beverages. So with that, if I can figure out how this works. Point it at the screen. Okay, technology is eluding the person that works for a technology company. There we go. Okay. When I was asked to speak, and especially to bring in innovation with health information exchange, I thought, well, you know, it's always interesting. We use words many times, and we really don't think about what they mean. So I went to the internet and looked at innovation. And as we all know, as the commercial says, the internet knows everything. Innovation, I thought was very interesting when I pulled down. New values through solutions, value add to new ways. Also refers to the use of a better, novel idea or method. And what I really loved was the last one, doing something different rather than doing the same thing better. You know, health information exchange is really a focal point. It is where, whether we like it or not, it all comes together. You can consider it almost a melting pot. And that brings opportunity. And so that's another way to look at it. Instead of an issue, a challenge, it's an opportunity. But we all know all this HIE stuff is really hard. It's not easy, because if it was, we would not be here today. We would have already had it done. So I look at things in terms of we're actually on a journey. And this journey will technically never end. But we are on a journey of discovery. And health information exchange is in the middle of that. Okay, can she do it? Yes, she did. And I've got another. There we go. With that, I started thinking back, and I was pulling this presentation together, and those who know me in my life before HIMSS, some say if you spend half your life volunteer for HIMSS, be careful, you'll end up like Pam, you'll become a staff member. I started looking at some of my slides that I could use, and I ran across the Florence Nightingale. Who has not ever seen this? Got to be pretty popular for a while. But I used this quite a bit when I was doing a lot of clinical outcomes research and activities. And, you know, I always thought that was very interesting, because this was in 1864. And she's talking about can't find the data in the medical record. And then, you know, how was the money spent? You know, was it of value? Very interesting. Then as I continue on, oh, here I go again. There we go. Now, this is something from 1999, and it's something that I actually pulled together, not that I'm wanting to display work that I've done in the past, but I think it serves a point. And you have to understand, I started in this industry when I was about 5 years old with that. But this is something that came about when I was doing consulting, and we were trying to work with clients to actually develop their plans for their technology, and I kept saying, what's the business strategy? What is the goals of the business, your operations, your workflow? What are you trying to achieve? And that's at various different levels. That's at a very high-level strategic view of the organization, all the way down to your patient care delivery activities, to the clinician, and for the patient. And I just laughed when I saw this, because look what's up there. We have long-term care, we have home health, we have population management, disease management. We're still talking about this, but it's different. This was more focused in a silo enterprise level, and I'm sitting here going, I can't believe this. No wonder this is familiar terms, but it takes, hey, wait a minute, what are we doing? We keep reinventing. It's like, if you look at what changes, okay, Pam's just technically challenged.
Both Pams are technically challenged, but if you hit those two round buttons, I think.
Well, that's the ones out there. Okay.
Cool.
Takes two Pams to operate the slide projector. But what does change? It's how technology is applied. It's how to look at our business and operation, and look at it in a little bit different way in terms of, do we keep doing the same way, the same thing the same way just because we always did it that way? And it's really looking at what am I doing and how can they be changed or adapted. I used to run into situations, even when I was working for a provider, rather alone, talking with other peers, and I would listen to what they were trying to do, and I said, why are you doing step B to get to C? Why is that? Oh, we've done it for 10 years. Well, can we change the process? Well, you know, we don't really need step B anymore to get to C. We never thought of it that way. So it's getting out of the box in terms of how you think. And with that, health information technology is an enabler. Health information exchange is not only an enabler, but it's been a game changer over our industry in the last few years. And it's really an enabler of something on such a broader scale than what we can even imagine, going back to the Thomas Edison quote. With Pam's comments earlier, she was talking about healthcare is in transition, is a cultural change. And that's what we're experiencing, because what comes with this is actual change in our business relationships. It's our business partners. We're working with people today, 5 years ago, we probably never thought we would be working with. People who we said, oh, we'll never work with that group over there, suddenly the walls are coming down. Again, this is not easy stuff. This is hard. I'm not fooling anyone in terms of this takes time and commitment. And that's where, moving forward, it's at different levels. It's at the business level as well as the technology level. And that's where the technology needs to be the enabler of the activities that we are doing, not technology the driver and forcing the business to form around it. The other aspect of technology, though, which I think we're in really exciting times about, is that it can be a game changer. I know I've been on several conversations with various folks, and their knees start shaking, and I can hear pens tapping on the desk, and they get all nervous, because I make comments like, you know, I wonder who's sitting in their garage, and whatever is that they're tinkering on will be a game changer and will really come in and just change how we even look at doing business, how we even exchange data, how we look at standards and interoperability, how HL7 may work with IHE profiles. Just totally game change. And of course, everyone's getting shaky, and they think I'm crazy. And then I go, 5 years, 10 years, did you think you'd have this little toy right here that was a major game changer? It's the smartphone. And now we're moving forward. This is not only for clinicians, but for consumers in their applications that they can use to document their clinical care. We don't know where all this is going yet. And I still keep thinking, is there someone in a garage somewhere that's going to come in and have one of those technology game changers that will really help propel this whole health information exchange activity forward like we've never seen it? Aha, she did it. So again, with this, it's not easy. That's the news, but that's where the rewards come from in terms of doing things that hasn't been done before. Health information exchange hasn't been done before in the manner that we've done it. How it was being occurred 5 years ago was new, and it's going to continue to be moved. In terms of, and don't worry, I'm not going to give a rendition of the last historical perspective of health information exchange for the last 5, 6 years, but I thought it was interesting to note, and then when I'm sitting in this and listening to Dr. Kaiser, I'm going, oh, I'm glad I put this in. How many people, well, I'm sure there's several people that remember the NEHIC report that came in 2008, and yes, someone was actually a co-chair of one of the groups who will not claim it, but that's where the industry through O&C was actually trying to put some definition around all that we're doing. And so we came up with the noun and the verb. And this definition has continued to be used over the few years. Now, what's interesting is, especially with Dr. Kaiser's comment, we have our own language. I get calls daily, it seems like, but very regularly, people, hey, someone's asked me to join a health information exchange. Can you help me understand this? Or just the other month, I get a call from a health information exchange. It's going to be public and private. Very interesting model, by the way, because it's going to be completely focused on consumer wellness, participating with the healthcare providers in their local community. Can't wait. But I'm explaining HIE 101. Have you ever, on the telephone, have to describe what the landscape is, rather alone what all the various acronyms mean and all the various versions of health information exchange? And while I'm trying to communicate this on the telephone, by the way, I'm going, I wish I had my whiteboard that they could see and I could draw this out. And by the time we get through with the conversation, many times these folks think, what are we trying to do? Build a new, exciting space shuttle? How come it's so complex? I don't get it. And also, within HIMSS, I think everyone has my phone number about if it even relates to health information exchange or a variation, call Pam Matthews. But again, I think back, we are not making it easy for ourselves, but what we are doing is not easy. It's hard. I go back, if it was easy, we'd have already had it done. The other game changer is, of course, ONC with the state level health cooperative agreement. That was a real game changer and put the states on the map in terms of health information exchange. Then we come to 2013, and now we're solidified that pretty much a lot of the general popular material is it's the verb, not the noun. And both are equally important because you have to have an entity that supports the exchange of data, but yet the verb is very important because now we are addressing those challenges and issues that do not really facilitate easily the exchange of data, especially within a system, cross systems such as clinical and financial, as well as across entities from one hospital to a local provider, as well as let's raise the ante up and let's do it regionally. Oh, let's raise the ante up, let's do it statewide, and let's do it at a national level. So rightly so, the verb is very important because that is the fundamental purpose of health information exchange. Also, the noun is still important. And this is where we come back to where sometimes the industry is not its own best friend. What's emerging now is that we have the public entities and we have the private entities. And then you have public and private collaborative entities. And there's benefits both ways. There's not one perfect solution that applies in every situation. And even now, I know we're all conversing about there's another definition of what is a private versus what is a public health information exchange. And it may be coming from inside the Beltway. We're not sure yet, but you're starting to hear a little pickup on that. And it's very different from what you see for these two. In terms of the private, traditionally has been the enterprise or a hospital-based integrated delivery system, where a public is more of your state-level health information exchange, regional health information exchange, a public-private collaborative. Borrowing some slides from our HIE symposium that we had in New Orleans this year, we had actual presentation on the landscape. Thought this was very interesting, where we are almost coming full circle in terms of, in 2010, where HIE has too little value, that goes back to 2008. I mean, it's been a fight uphill. This is not new. But then look what is in 2013. It's too valuable. And that's where we get into the data, and that gets into Pam's comments earlier, where data is keen, and the ability to have data analytics across geographic areas, across geographic populations, that's valuable. And that's what health information exchange organizations can bring to the table. Someone's wanting to do some more chair dancing down there. And then with Mickey Tripathi, another point in the health information exchange timeline, the HIE is maturing as he made his presentation at the Standards Committee in January. And here we start seeing health information exchange 2.0. Again, the verb is the focus, but analytics is what is key, at least from my perspective in this comparison. And again, it's the nomenclature, because how many times have we seen HIE 2.0, and I get questions going, well, what happened to 1.0? What happened there? And is there going to be a 3.0, by the way? So that's where it's when I speak to people like that, I say, don't get caught up in that terminology. Don't get caught up in the nomenclature. Stay focused on the goal and getting to the end. So where are we today? We're really where the rubber hits the road. We're at results driven. We really think, even within HIMSS, our HIE symposium, the volunteers actually came up with that actual theme for the symposium that was on the planning committee, not HIMSS. So everyone is focused on the results, where the rubber is hitting the road. The drivers, of course, it's the government, it's the federal government, it's the state government. However, it's also other things that are driving that: the consumer, the patient, changing expectations, how to deal with younger patients with technology, how to deal with older patients who refuses to deal with technology, how do you deal with the white space such as the rural areas that was just mentioned. So what we're seeing is the result, new business relationships. Out of that, new technology will form, and also new creativity where the technology and the business will be used in ways that we've never thought of before. Because again, 5 to 10 years from now, what will this be like? Or will we even have this? Or will we need this? What is clear is that a lot is happening at the state and local level. Yes, the federal government does have a lot of initiatives, but what we're seeing is a lot is happening at that state and local level. It's occurring at that grassroots level. And what is occurring is new relationships. At a higher level, we have Healthy Way, which, as everyone knows, the NHIN, Nationwide Health Information Network, went through several evolutions, spun off private 501c3, and now it's its own independent entity and moving forward. With that, they developed a new testing program. Wait a minute, we have a relationship here, the HIE Interoperability Work Group. I remember at the HIMSS symposium, I think in, what was it, Florida? I'm not sure which, but I remember it was their first meeting because Dave Minch is walking out of the room waving at me, and I knew he was going to their first meeting to talk about it. So again, new relationships forming. And that's a little bit about the interoperability work group. But again, look, 19 states, 21 vendors, 22 HIE vendors, 21 EHR vendors. Again, new relationships we never thought about. Connectivity Consortium, again, a new group. Providers, again, primary purpose, and the primary purpose of all of these groups in some manner is the basic exchange of information and facilitating that. And again, we're collaborating now with Healthy Way. Commonwealth Alliance is probably one of the newest ones. Again, right after HIMSS conference this year is when they made their announcement. And again, they're working with HIT vendors. This I will not go into elaborate on because I think that's already been mentioned several times. And as far as the question, here's a great map. Pam, if you would like to use it, because I think there was a question and everyone was counting. Feel free to utilize this. Oh, sorry. So the point of that, these initiatives we just went through, while the federal government and their initiatives may have touched on them, they were being driven by individuals that were not federal employees or under a federal agency. So again, new business relationships and new business partners we've never even seen before, learning to work together and finding a common business need. Now, the federal government is also still in the play. Even though many of the programs are winding down, they've just announced the HIE Governance Forum. And then also with that, again, new relationships. The EHR Interoperability Work Group and Direct Trust, once again. So because the Interoperability Work Group, that group is there for the federal government to actually rely on to pull into their activities. Had they not taken the initiative several years ago to play together, they could not be leveraged with their capital expertise. Beacon's Community Program. I thought this was very good to bring up just as a reminder. Everyone knows this program is winding down, but this was their report, and we also know health information exchange is very critical to many of the Beacon programs that are out there. in terms of outreach, sustainability, clinical quality improvements, these are pretty substantial numbers that's being demonstrated from these groups, from the Beacon communities. And so what I think is occurring, there's many, many, many more of these, and they're happening at the state level, local level, and regional level. It may be small incremental steps that small groups are coming together, and then they may form a partner with another group from another region. It could also be state-driven initiatives or a statewide initiative. That's at the grassroots level where I think, personally think, the real innovation, the real adoption, achievement, and advancement of health information exchange will occur. So, given the DARE, this is where I challenge you between today and tomorrow to document what your relationships. Pam's already been talking about those. Several of the speakers have been talking about those. California, I think, is rich with developing these relationships from a business perspective. So your challenge is, let's document a lot of this to show the other states and the federal government what can be accomplished. So we talked about new relationships. Well, new relationships come from drivers. And that's a fancy word for saying there's a need. So what are the needs? This is a list of what we are seeing, and I would say it's not specifically limited to state-level health information exchange or state-level initiatives. Can occur from regional or local, or even some of the private health information exchanges. And by the way, not all private health information exchanges could be actually a hospital or integrated delivery system. Could be other types of private exchanges. Again, getting back to comments earlier today, the data, big data. Going back to the earlier slide, that's a big difference of what we're seeing in the past with health information exchange to now. Data is the key, and the ability to have data analytics. So that is coming across loud and clear, regardless of how people are doing, achieving, trying to obtain the data, exchange the data, utilize the data. That is a primary focus. The other thing, besides performance reporting and the new healthcare reform and payment changes, the other thing that I think we hear next to the data and data analytics is consumer and patient engagement. That's tough. What does that mean? And it can mean a lot of different things depending on your patients and the consumer target that you are working with. New emerging services. Now, if you probably look at this, you'll say, oh, we're already doing A, B, and C. This is, again, thinking of it from a national perspective, trying to bring that perspective to your forum today. Looking at this, what is new and emerging to one person may not be new and emerging to another. So always keep that in mind. And that's where this type of forum, where you have the free exchange of data, collaboration, is very crucial, because there's no need to reinvent the wheel. But always keep in mind, what's new and emerging for someone may be something that's just a dream in the future for someone else. And again, look at what we have: clinical analytics, public health, community health, population health, SNF, long-term care, medical home, claims data, consumer, payer health information exchanges. They're out there. So having said that, again, given that there's dependencies on the state, the geographic area, the market, as well as state laws and how that interfaces with federal laws. These are the general items that we hear, which is a big difference in the type of areas that folks were focusing on just 5 years ago with health information exchange. This has greatly expanded. Other ways that states and state-level health information exchange, they're exploring ways to work across interagency. Now, this is more of a state-specific, but they're really looking where they can. How can you build once, utilize multiple times? I know I can say that, and people say, oh, that's not happening, but it is occurring. Now, it may be at a conversation level at a state. This isn't easy, but it is occurring. And that's where you build the technology once, you use it across multiple agencies, across multiple platforms, but what's really critical is you use it across multiple functions, from eligibility checking to lab results reporting, e-prescribing, from the state-level HIE. It's whatever the state and that initiative is trying to achieve. Again, not easy. Value statements. The third and the fourth, I think, are the most important and the biggest game changer that I've seen even from 5 years ago. We do hear health information exchanges can provide a very easy way to exchange data when there is not that method available for a provider or for a client. However, what I'm really hearing more and more about is it may be incremental, it may be small, but states are having results with demonstrating incremental exchange in patient behavior, which then ties back to clinical outcomes, which then ties back to wellness. So it's happening. It's incremental, but it's happening. The other things that we hear, of course, direct messaging. That's being very popular, especially with some organizations that find it really tough to gear up from a technology and business perspective. With the recent messaging from ONC, we know that they're very interested in having everyone deploy direct with that. But, you know, one of the things with health information exchange, again, is providing that service, especially if they have multiple ways to connect to that exchange in areas that may not have a way to exchange. Rural is, I actually live in a designated rural area. My primary hospital is a critical access hospital. So it's tough for these type of areas. Some health information exchanges are making inroads in that rural area. The other thing that's becoming very prominent is public health and all of that goes along with public health, whether it's registries, reporting, but public health is another area that states are looking at. I will say, and not to put a plug, next month we'll have a report that we'll release that was a joint effort with NASCIO, the State Association of State CIOs. And we actually looked across not only state-level HIEs, but what they were doing with their Medicaid enrollment, their Medicaid systems, and several other key topic areas. So look forward to that report. It'll be coming out, and then when you see some of this information, again, you'll just act like you've never seen it before, and you'll be totally surprised. But again, here I go with the double dog dare. Change these slides to be the California story. For a technical, I could spend half the day, and I know someone made the mention they were so afraid this would be so technical, and I try to look at the technical aspect, and I could certainly do that deep dive, but who is interested on a afternoon at about 4:30 and you're waiting for the network reception to start talking about technical aspects? So I thought, and I said, let me take something that came out of the HIE symposium this year. And this is actually from a very large health information exchange that is serving as a state, but also because of not a whole lot of other HIE options in their state, they have a lot of different purposes. They're the state designated entity. They're not owned and operated by the state. The state has the oversight. You notice I'm not naming names to protect the innocent here. But this is what their statement was. it's not one solution fits all. They spend, and they will say, they spent so much time trying to figure out, do I do technical solution A, B, or C? Ended up, they're doing both in terms of being centralized and federated. They actually went through the same process with Query, Connect, Direct, and I could go on and on. At the end of the day, they got it. And for them, it isn't about one or the other. It's that it will be a lot of different things. And that, again, goes back to the specific health information exchange. So what have we learned from 2008? One size does not fit all, and it doesn't fit all from the business drivers to the service offerings of the health information exchange, and doesn't fit for the technical infrastructure or the technical strategy. But that's the opportunity, because you don't have to fit a one size fits all. You can ensure your success, which includes sustainability, by mapping to what you think you can sustain over long term, not what someone else has said. So again, where we are today, it's not pretty. I mean, it's not really a very, I wouldn't say it's not pretty, but if many times I get calls and people are wanting the canned answer. What vendor did you select? Or what vendor did someone select and wanted a one vendor solution? Or tell me the easy answer. There's no easy answers. But where we are today is we have multiple options, and it ranges from a national level for participation to a state level participation, as well as if we do need to go to the point-to-point, or something like direct. But again, many options, but again, what's interesting, what's at the bottom? Consumer-mediated health information exchange. That's going to be tough. I actually stole that slide from Delph Cover, and I know he's up in Maine, but I think it applies across a pretty broad area, and it's pretty fundamental. Already talked about the trust, a lot of the activities going on in California regarding the trust, and how do you create that trust to even then start talking about the physical exchange of data, the business value of data, then also being creative and innovative. And then what's the value to the stakeholders and the customers, and always learning from others. So again, how much time do we have here that we have left? 25 minutes, okay. So really, we did not plan this, but what I wanted to do is, instead of me actually having more conversation about health information exchange, and given the direction that this is a forum for everyone to share their ideas, what I wanted to do, and this fits very nicely in terms of who would like to give examples? And it may not be examples of what you're doing in California. Maybe it's something you've seen somewhere else, such as Crescent City and what those guys are doing in Louisiana, for example, or Colorado. They're doing great things, especially in behavioral health. What are some of the things that you've heard about, you may be involved in, that you think is really innovative, that you said, God, I wish I had thought about that? What are some of those things? So this is going to be my challenge here for the rest of the time. The other challenge that I have, and I'm sorry I'm not going to be with you tomorrow, but my challenge to all of you, take this deck and make it California's deck. Now, it could be some things you'll repeat, but make it your story. Make it your deck, because you have a story to tell. And again, with that, I will say, I go back to what I said first. If this was easy, we would have already had this done. It's not. And the journey's not going to end anytime soon, but we're going to be in a journey for a while. So with that, let me open it up. And who's the first to take the dare?
So I actually do want to talk about something that originated in California because I think it's very important, and I don't know that it's gotten the recognition that it deserves. But it's a little thing called HIE Ready, and it's a check program. And the neat thing about HIE Ready is that it started with a group of 4 people who saw the regional extension centers. They saw ARA and the regional extension centers, and they said, "Oh my God, we have a real problem here because we don't have any standards for a set of HL7 interface. We don't have any set of interfaces that we can go to all of the HIE vendors and say, you need to do these things." So that small group of people got together, put together a standard set of interfaces, and through a number of iterations, and thankfully it was adopted by CHEC, and it's grown into a very successful program. And I was actually hoping sometime between today and tomorrow we'd actually find out how widely used it now is with the HIEs. But I think it's an extremely important program and deserves a lot of recognition because I think it's really helped to improve the interoperability of the EHRs. So that's mine.
Very good, thank you. Who's someone else? If someone else doesn't stand up, it's going to be a long 25 minutes. Oh, come on. Wait, did I see a hand over here? There you go. While the mic is getting over there, one of the things that I'm seeing a lot is that exchanges and the organizations are looking at new medical services to tap into. There were a lot of federal monies around behavioral health. There's also a lot of state grants. One of the areas on oncology, and I was very interested seeing that. End of June, I'm actually going to be facilitating a session with another association focused on oncology treatment centers. And they've been knocking at the door in terms of these folks are asking them, hey, connect with my health information exchange. And they're going, we need to know a whole lot more about health information exchange. So I think one of the things we'll start seeing is that very specific medical service areas, oncology was a great example. You'll start seeing more focus on those services and how that service provider and how the health information exchange entity can start working together, what the data set is. Of course, some of it's given, patient demographics, but there's very unique data requirements if you start working with oncology patients across multiple providers. Also, the continuity of care document that's in meaningful use with the HIE supporting that will also. So again, be on the lookout for all the various medical services that could be popping up that could be a business model.
Pam? Hi, Bill Behe with Santa Cruz HIE. One of the most innovative things that comes to mind, unfortunately, we don't have in Santa Cruz, but I've seen this in a few places around the country. I think it bears some thought, which is that in an inpatient setting, like in an emergency room, that the inpatient emergency room system has wired itself so that it does a query automatically in the background of the health information exchange and just comes back and turns on a little light or something like that in the emergency room system, alerting the doctor that there's other information about this patient in these external systems. So they don't have to proactively go out and look for it, but that they're told there's information there, and then with one click of the button they can retrieve that. And I was just very taken with that as an innovative item. Ah,
interesting. And then does it populate their record with the data coming out of the HIE into that hospital record, or is it
typically not?
Okay.
Because you don't want to automatically bring in a lot of data. So typically not, but it brings up another window of this data, and some of the systems can pull it across and populate it, but most of them just allow a view so that a provider can make a better decision.
Ah, very good. Someone else? Up, we have another one. Oh, wait a minute. Wait a minute. Let's go over there. While the mic is going over there, another this was a very local geographic area, again, an example of a need, and it's by the geographic area, a very localized community. I call it a community health information exchange because it was in a designated rural area in a large section of the state, and that whole section is rural, so you can count the number of major hospitals on one hand over across about 15 counties. One area, two major players in terms of the hospital, always very competitive over that patient, and because the patient could go to either one, they put down the competitive views, came to the table on emergency department, actually pulled in the first responders, formed the formation of this health information exchange across this multi-county area that was primarily the two hospitals. They purposely made it a public entity, started out with the first responders, emergency room, where they knew patients were traveling back and forth to the ERs for various reasons, so they could identify when the patient was from another doctor from the other hospital, or you had a patient that liked to circle the ERs on a routine basis. That provided the basis to bring the employers to the table, and now that's provided the foundation for a much larger business for that health information exchange, but it all started with the emergency room.
Hi, my name is Sunny, and we're service partners for the two recs, Calypso and Corec. What I'm going to say is it's not an innovative idea, but an innovative approach to increase adoption. I think this is a shout out to Corec. What they're trying to do is providers over there use around 50 different EHRs, and these are solo practitioners, most of them, and the overhead to implement an interface is pretty expensive. And what Corec is trying to do is they're trying to use some of their leftover RF funding to develop interfaces for these vendors and join OCPRIO, which is a local health information exchange. And I think they've put that in their budget, and if that gets approved, I think that's and if that happens within the timeline by the time they run out their ONC funding, I think that's a good idea, because that brings a whole bunch of 1,000 providers and OCPRIO pretty quickly and effectively. So that's just I thought that's an innovative approach.
Right.
Yeah.
And again, part of the innovation is it's not necessarily totally new. It's taking something that you may already be doing and thinking of it a little bit differently, tweak it a little bit differently, making it a little bit new, but fundamentally it's not really new, and it's not something that's earth-shattering, but boy, does it get the job done. Pam, I think you lost your train of thought. Oh, you lost your mic. We're micless. Micless. Do we have a mic? Right over, yeah, there you go.
So I have a question, but we're going to pretend the deputy secretary isn't asking the question. We're going to pretend that some other person who, as a medical records person, is asking the question. And that is, so the key to the emergency room example that Bill brought up, where the patient shows up in the emergency room and it triggers a query, goes back to identifying the correct patient.
Correct.
And so, from a HIMSS perspective, where are we nationally, or are we anywhere nationally with that discussion? Again, that was part of the original HIPAA. I know it's an ugly topic, and
by federal law, and subsequent to that law, it's in a holding queue, just to put it very bluntly. From the HIMSS perspective, if you read our public policy principles, as well as what we have been advocating as an organization, is that at least minimally, funding needs to be set aside to study. We acknowledge that due to the federal statute and the situation of the federal statute, that no direct work can be in terms of identifying a solution. However, it doesn't negate the possibility of studying and commissioning a study that can help lead to future activities, such as something that would help facilitate that in a more uniform basis. Did I dance around that? Thank you. Thank you. I get an A for... I did it.
Because that's a huge issue.
It's a very big issue.
I lived in a pretty small community, a very small community in California. There was another family in that community, and they mailed me her lab results by mistake. There was also only one physician group in that town. So, and that's, if it could happen to me,
I mean, I'm sure we all have those stories. I have one. My cousin and I were in college. My legal name, Pamela V. Matthews. My cousin's legal name, Pamela V. Matthews. Mine's Virginia. I'm a state. And then hers was Victoria. I'm in nursing. She's in something else, but she had straight A's where I was in nursing. Pulling long hours. Never made a C, though. I will say that. So having said that, I loved it when I went up. Oh, you're on the honor roll. Oh, yes, I am. It was my cousin. So, yes. There's, if anything, what ideally should happen or ideally could happen is we study this as an industry and we look at what solutions, not a technical vendor solution per se, but what solutions could be viable that would help move this initiative forward and reduce the challenges and reduce the risk and the potential of problematic patient quality issues. I think there was someone in the back who... I can everyone hear?
I'll just start. I'm Walter Shajansky, and I just wanted to talk about a project that I'm not sure how innovative it is or not, but it's happening here in California, and it's different. Let's say it's different, and that may be noteworthy. We are involved with a health information exchange project in North San Diego County that is focusing exclusively on direct messaging with the strategy of maximum adoption through minimal technology requirements and minimal cost, and really exploring what are the benefits as well as the limitations of direct messaging unto itself without any of the other trappings of a RIO or an HIE, the noun. And we're finding that it's fitting into an interesting niche right off the bat in terms of providing more functionality than the faxing that's currently happening in certain regards. And so it's, in a sense, it's competing with faxing, but the participants are finding it's providing more functionality, better audit trail of what's happening, and so forth. And it's also, in a sense, competing with HL7 messaging in that the participants are finding that it's much easier to implement than HL7 messaging and less cost than HL7 messaging, providing a lot of the functionality, at least at the transport level. And so we're exploring various use cases and technology implementations of direct messaging, various levels of integration with EHRs or not integration with EHRs, and finding that there's a substantial amount of value in direct messaging unto itself without introducing a lot of the costs, governance complications, patient consent complications, and so forth of the larger HIE model.
Very good. Thank you. Regina. Where's Regina? Regina.
Hey, going back to the topic we just had, we talked all about electronic records as the ability to do digital avatars that are attached to the record. We now have Facebook and Google doing facial recognition. How about we just sidestep this unique identifier, then the human face itself becomes the unique identifier.
Whoa. What do you think?
Did you hear what I said?
We all heard, yes.
Okay.
We all clapped, yes. Now, again, what she did, thinking of something we have and use it in a different way. Very innovative. Think about that. I don't have an answer for you. I'm still thinking on that. But that's exactly when you start talking about innovation, you start really trying to press the envelope, or we used to call it pushing the envelope, a lot of different phrases there, but that's what starts happening. Why not? I think we have 5 more minutes. 5 more minutes, go right ahead.
Larry Ozran, it is on. We're looking to do one of your bullet items, which is to create consumer-mediated HIE, turn
wow.
HIE upside down. So instead of being provider to provider, it's basically provider to patient bidirectionally.
And where are you with that? Or
I would say we're in the first 10% of that.
first 10%. Okay, what do you see as the most challenging thing in front
The
of you?
same challenge that every HIE sees, which is actually getting the data out in a format that you can utilize and store it in a standard format so that you can then reuse it.
What do you think will be the biggest, this is not a drill, by the way.
But it's still helpful.
What do you perceive as the biggest selling point for the consumer to participate?
They have control over their data.
Ah, very good. And will you have these little devices for me to use?
They'll be able to connect to their information through their device.
Very good. And how will you use that with the provider then? Or will you? Is it strictly up to what if the provider comes to you and asks?
Provider comes to us and asks for what?
The data.
That's up to the patient.
Up to the patient. Very good. Very good. We probably have just a few more minutes.
One question here.
Yes.
Okay. So we're all, the old expression, be careful of what you ask for. What if this is really a roaring success, and especially for the hospitalists and others in the hospital environment, where you get a fire hose type of data flow at you. You walk into the patient room, and picking up on Bill B, his earlier comment, do you really want to take 10, 15, half an hour, depending on how many years of data is flowing at you as you walk into the patient's room? And the liability exposure for physicians and hospitals in particular who don't take a look at what's already out there. I'm not sure we're really looking at those questions yet. We've tiptoed around them for a couple of years, but not really ready for those. Thanks.
Excellent. Who has some experience with what he just talked about that you would like to share? Because it's really interesting when suddenly I'm the clinician, I'm at the bedside, I'm treating the patient, and bam, how am I dealing with it? Because what fundamentally you get into, especially if you're dealing with some of the older generation, is how they learn to practice medicine. And not only their thought process, but also some of their props. Because when I was involved with a EHR installation at a large provider, one of the medical directors of a service pulled me aside and just reamed me out. I knew the guy. I knew he wasn't, if he was at this point of frustration, there was a reason why. This always stuck with me. I took away his thought time when I suddenly said, here's an electronic EHR and you do it in front of the patient. He had actually used the time to go to the doctor's room, if those are still there in a hospital, to look at the chart. But it wasn't that he was sitting there charting, he was thinking. So and that was just one small example. What you start getting into when you go down this path with the clinician, and that's going to vary, again, what we said even with HIE, one size doesn't fit all, one size does not fit all for a clinician, whether you're an MD, PA, nurse, LPN, assistant. So that's the fundamental areas that you're hitting on, is how they do work every day, how they practice medicine, their thought process, as well as it could be a prop, whether it's going away somewhere where they perceive as quiet to think, or they have a chart and they're thumbing through and they're just used to that prop. You had a follow-up? Yes, go ahead.
I mean, part of it depends on what perspective they're coming from. There's a difference between data and information. Sorry, thank you. There's a difference between data and information.
Yes.
So if you throw people a pipe full of data, that's not useful to them. So a lot of it has to do with the presentation of the data, as opposed to just getting a pipe full of data. So to his point, and to yours as well, it has to work in the workflow in a way that the provider can utilize it.
Excellent, excellent. One more, and I bet we're about at the 5-minute mark, but one more. Yes, go ahead. No, two. Can we do two? Two, real
Mine's
quick.
just a quick follow-up on the discussion there and ties to the ED example. We started and actually implemented an exchange with another organization, but the problem that we have internally is, and the comment was, we don't want to take that data into our system, but if you don't take that data into the system and a clinical decision is made based on that, and then legal comes back later because there was an adverse event, and you say, why did you make that decision? You say, well, I went and got this data over here. When you can't produce that data, you've got a significant issue, and so that's been a real struggle for us.
Very much so. And then one other comment?
I had to ask Pam if it was okay to give a vendor example. She said it was fine. So at WellPoint, we're working with providing the provider and between payer, and what WellPoint did was they ingested 18,000 patient records and used that to automate the payment process to their providers. And as the system gets more information, it's able to more accurately provide payments in a quicker time. So.
And I would just wrap up and say thank you for having me. I hope this was beneficial for me. If anything, we got conversation going, and we definitely came up with an innovative idea out of this. So with that, and I hope you have a great session tomorrow, and look forward to hearing more great things from California.